Welcome everyone, this is Premier Support Channel, and in this medical YouTube video class, we will cover alcoholic fatty liver disease, a core topic in hepatology. We will review its pathophysiology, clinical presentation, diagnosis and management in detail. Let's begin. Alcoholic fatty liver disease happens when fat starts to accumulate in your liver due to long-term heavy alcohol use. It's often the first stage of alcohol-related liver problems. Alcoholic liver disease or ALD represents a spectrum. It starts with alcoholic fatty liver, progresses to alcoholic hepatitis, and in advanced cases leads to cirrhosis. Alcoholic fatty liver disease AFLD, the focus of today's video, is the earliest and most reversible stage. AFLD is highly prevalent among heavy drinkers, and although it may seem benign initially, it has the potential to progress. Alcoholic liver disease accounts for up to the half of all liver-related mortalities worldwide. Alcoholic fatty liver disease can occur within weeks of binge drinking. Pathophysiology. When we drink alcohol, it enters the liver, where it's broken down by special enzymes. One of the main byproducts is acetaldehyde, which is a toxic substance. This chemical damages liver cells. As alcohol is broken down, it increases a substance called NADH inside the liver. High NADH levels do two harmful things. First, they slow down fat burning, also known as beta oxidation. Second, they increase fat production or lipogenesis. So fat starts to build up inside liver cells because it's not being broken down, and more fat is being made. This leads to hepatic steatosis, also called fatty liver. Meanwhile, acetaldehyde and the excess fat also cause oxidative stress, which means harmful free radicals start damaging the cells. This damage triggers inflammation and activates immune cells in the liver, especially Kupffer cells. If alcohol use continues, this simple fat buildup can progress to alcoholic hepatitis and eventually to cirrhosis, which is irreversible scarring of the liver. Alcoholic fatty liver disease is often silent and incidentally found. When symptoms do occur, they are vague, like right upper quadrant discomfort or fatigue. AST to ALT ratio is greater than 2:1 is a common but not definitive marker. Initial evaluation involves labs and imaging. There will be increased levels of AST or aspartate aminotransferase, ALT alanine aminotransferase, GGT gamma glutamyl transferase, MCV mean corpuscular volume in lab values. Ultrasound shows a bright liver. FibroScan can evaluate fibrosis non-invasively. Liver biopsy is gold standard but reserved for diagnostic uncertainty or suspicion of overlapping liver disease. Alcoholic fatty liver disease and non-alcoholic fatty liver disease may look similar histologically, but their causes and associated metabolic profiles differ. Careful history is the key to distinguishing them. Alcohol use is more in alcoholic fatty liver disease, whereas minimum or nil in non-alcoholic type. AST to ALT ratio is more than 2:1 in alcoholic and less than 1:1 in non-alcoholic. GGT gamma glutamyl transferase is more elevated in alcoholic fatty liver disease. Finally, alcohol and malnutrition are major risk factors in alcoholic fatty liver disease. In case of non-alcoholic type, they are obesity and diabetes. Management begins with the complete cessation of alcohol. Nutritional support is often needed, especially in malnourished patients. Address obesity, diabetes, and hyperlipidemia if present. Psychosocial intervention is crucial for long-term sobriety. There is no approved pharmacologic therapy for alcoholic fatty liver disease itself. You can give vitamin E or metformin in selected cases. But if alcohol use disorder is present, agents like naltrexone or acamprosat can support abstinence. Avoid hepatotoxic medications also. Here are some exam crucial tips. AST to ALT ratio will be greater than 2:1. Macrocytic anemia and high GGT should make you think of alcohol-related disease. Always look for other causes of liver injury, especially viral and metabolic. Thanks for joining this video class. I hope this video have helped you to become a better learner. If you have questions or case scenarios you would like to discuss, leave a comment below. Don't forget to subscribe for more clinical medicine videos. See you next time.